really grateful for the opportunity to present today. So the topic I chose is inherited thrombophilia and navigating the diagnosis of, testing or not testing, and how that affect management in the clinical setting. So in terms of, the objectives today, I'll talk about the history of hereditary thrombophilia discovery and testing, briefly discuss the underlying mechanisms that contribute to inherited thrombophilia, and then we'll sort of go into specific patient scenarios where screening might be indicated. And around these cases, discuss the prevalence of inherited thrombophilia and its implications on first and recurrent VTE risk. And then we'll sort of look at the current evidence and guideline recommendations for selection of screening and determine how positive screening might change management, including choices regarding long-term anticoagulation, thromboprophylaxis, and reproductive health. So when we look at the history of inherited thrombophilia, this is a relatively new concept. So the first time the term thrombophilia was used was actually in 1937, referring to, increased risk of arterial thrombosis, actually. And then around the 1950s, it was, noticed that certain families had increased venous thromboembolism risk within the family. And it wasn't until 1965 when the first, mutation that can cause or increase the risk of VTE was diagnosed in Norwegian families. And so the first one was antithrombin deficiency. And then in the 1980s, protein CNS deficiencies were discovered. And then it wasn't actually until the 1990s when they identified factor V Leiden and prothrombin gene mutations. And then sort of the 1990s onwards, we started to notice like familial patterns and how these mutations can be associated with increased VTE risk, especially in the setting of oral contraceptives and other minor transient risk factors. And so, over time, when these were first identified, there was a lot of testing, especially in families who are at higher risk. And then slowly over time, seems like we're moving away from testing for the most part, and now only testing like in very specific situations where it might affect management. When we look at, the 5 most common inherited thrombophilia, mutations, there have been other mutations, so things like increased factor VIII and factor IX, but these haven't really been linked clinically to like any, actual risk that, affects patient management. But in terms of the 5 most common, we have the factor V Leiden, which causes activated protein C resistance. And then, the natural, anticoagulant deficiencies. So activated protein C, protein S, and antithrombin deficiency. And then the gain of function mutation at the prothrombin level. So the first scenario I wanted to discuss was, a young patient who presents with a weakly provoked VTE. And an example of that, was actually a patient I saw in clinic this block a couple of weeks ago. A healthy male who was diagnosed with community-acquired pneumonia, was treated with antibiotics in the outpatient setting. Sounds like was quite immobile at home, like still walking around the house and going to the washroom, but after he finished his antibiotic course, he presented with worsening dyspnea and hemoptysis and was found to have a submassive pulmonary embolism. And then another scenario that I've come across not infrequently is, middle-aged male who's an athlete coming in with a proximal DVT after having sustained, a minor injury while playing, soccer or hockey. So not like in a cast, not a fracture, but maybe a minor hit to the leg and comes in with a DVT. And so in these situations, do we test for inherited thrombophilia? And if we do, how does that affect management? And I think the first question I asked, well, how common are inherited thrombophilias? So we know that, they're actually not very common when we look at, antithrombin deficiency and protein CNS deficiency in the general population. Factor V Leiden and prothrombin gene mutation are more common, so 3 to 7% in the general population, up to 4% for prothrombin gene mutation. And factor V Leiden prothrombin gene mutation seems to be more prevalent in Caucasian patients. But when we look at the prevalence in patients who are diagnosed with VTE, it's much more common. And when we look at it in total, sort of combined, looking at all 5 mutations, it's up to 30% of patients who are diagnosed with VTE can have an inherited thrombophilia if you go looking. When we look at sort of higher risk mutations, so things like homozygosity for factor V Leiden or prothrombin gene mutation and compound heterozygosity, they're sort of less common. So we're looking at like less than 0.1%, in terms of prevalence in the general population. So I guess if it's common, then what does it mean? What are the clinical implications in terms of VTE risk and management? And so looking at this systematic review and meta-analysis recently published August 2024 in Annals of Hematology, it looked at a total of 107 studies in 38 different countries between 1990 and 2023, and almost 20% of the studies they looked at were actually published recently after 2015. And in total, the study looked at 107,000 patients, 21,000 of whom had experienced a VTE. And hereditary thrombophilia was diagnosed in 22% of VTE patients, so almost a third of the patients. And the mean age of the patients in the study was around 46, 47, and almost half of them were male. So in the study, they looked at, risk of first or primary VTE in the setting of these mutations, and then risk of recurrent VTE. So we know for something like heterozygous factor V Leiden and homozygous factor V Leiden, the risk of primary VTE is high, but that doesn't seem to be the case for recurrent VTE and heterozygous factor V Leiden. Maybe for homozygous factor V Leiden, there is a signal towards increased risk of recurrence. But again, like the prevalence of homozygosity, it's quite rare, and usually patients have a strong family history in that setting. And sort of similarly for heterozygous patients for prothrombin gene mutation, increased risk of primary VTE, not so much for recurrent VTE. Again, for the homozygous patients, they actually didn't even have enough data to document recurrence risk because it's so rare. And similar for compound heterozygosity, again, increased risk of primary VTE, not enough data to calculate recurrence risk. And then when we look at sort of the more, thrombophilic mutations for protein CNS deficiency and antithrombin deficiency, again, very similar pattern. Increased risk of primary, but not so much for recurrent VTE, maybe a little bit for the antithrombin deficiency, a little bit higher, but again, not significant. So again, this is another study published in ASH in 2016, looking at relative risk of first VTE. So I think highest in the setting of, protein S deficiency and antithrombin deficiency with a relative risk of almost 10. But then when we look at the risk of recurrent VTE, again, not so much. Maybe antithrombin deficiency, there's a signal, but in general, not very high risk for recurrent VTE. And then there's this interesting study that I found the results were a little bit counterintuitive, but it was published in Annals of Vascular Surgery in January of this year, specifically looking at prothrombin gene mutation and the risk of recurrent VTE. And it looked at 16 prospective cohort studies with 16,000 patients included. And they found that carriers of the mutation were at increased risk of recurrent VTE, and they actually say this risk was specifically observed in patients who are heterozygous and with a relative risk of 1.79. And the authors conclude that the individuals with heterozygous prothrombin gene mutation who have experienced a VTE episode are at 79% increased risk of recurrent VTE, but they only saw this effect after 5 years of follow-up. So I guess what are the clinical implications then? Whether patients presenting with the first episode of VTE have a hereditary thrombophilia, if it doesn't really affect the risk of recurrence, maybe only in patients who are homozygous for factor V Leiden, maybe heterozygous for prothrombin gene mutation, although I'm not too sure about that one. And we don't really have enough evidence for homozygous protein thrombin gene mutation and combined heterozygous patients because it's so rare. So, I think whether or not the patient has an inherited thrombophilia shouldn't really affect treatment decisions in terms of, the recurrence risk and how long we decide to treat them. And, if we actually test these patients and then then the screen is negative, we might actually provide false reassurance that the recurrence risk is low when it actually isn't. So what do the guidelines say in this situation? So when we look at the ASH 2023 guidelines, they say, for unprovoked VTE, we do not test. For VTE provoked by surgery, do not test. But then they say for VTE provoked by non-surgical major transient risk factor, then we do test. And then they recommend indefinite anticoagulation for these patients. And so that includes even patients who, have like broken a leg and are immobile in a cast, which, we generally think of as a strong provoking factor. And they think these patients, if they test positive, then they should remain on indefinite anticoagulation, which is not really what I've seen, commonly done in clinical practice. But then they don't really talk about, the more minor transient risk factors and what you should do in that situation when you're on the fence, especially if it's a very young patient who's active, what to do in that setting. And so when they talk about the major transient risk factors or non-surgical risk factors, so things like confinement to bed, combination of minor transient risk factors, admission to hospital for 3 days, or confinement to bed out of hospital for at least 3 days with an acute illness, and then a leg injury with decreased mobility for at least 3 days. And then they sort of have, like, in the fine text, they say the decision to test may depend on the strength of the provoking factor and whether VTE occurred despite the patient being on thromboprophylaxis. But then they don't really say, so if the patient was on DVT prophylaxis, should you test or not test? And they don't really, explain either way. And when we look at the British Society of Hematology guidelines, they say that testing for hereditary thrombophilic traits after a venous thrombotic event is not recommended as a routine guide to management decisions. And then they don't really, go into detail about whether or not it was provoked. CHEST guidelines in 2021, they don't really make a comment on inherited thrombophilia testing. And then the NICE guidelines, most recently updated in August of 2023, they say, do not offer testing for people who are continuing anticoagulation anyway, because it's not going to change management. Do not offer it if patients have had a provoked event. Then they sort of talk about antiphospholipid antibodies. And then they say, consider testing for hereditary thrombophilia in patients who've had unprovoked DVT or PE and have a first-degree relative who has had a DVT or PE if they're planning to stop anticoagulation. But, being aware that these tests can be affected by anticoagulants. And so, in the setting of unprovoked DVT or PE, that sort of goes against what ASH recommends. And they say that provoked PE or DVT is sort of similar to the ASH the definition. So recent surgery, trauma, significant immobility, pregnancy, but here they consider, pregnancy or hormonal therapy also provoked. And then finally, looking at the European Society of Cardiology guidelines, they say patients who are carriers, I apologize for the crowded slide, but essentially they say that patients who are carriers, with these confirmed mutations are often candidates for indefinite anticoagulation, just based on the fact that they have the mutation after a first episode of PE in the absence of a major reversible risk factor, which I don't know if they're, whether or not, if they don't have a major provoking risk factor, they need indefinite anticoagulation anyway. So I don't know if I totally agree with that statement. And then they say, in view of these possible implications, testing for thrombophilia may be considered in patients who have a VTE at a young age in the absence of an otherwise identifiable risk factor. So again, they're sort of recommending screening in unprovoked young patients, especially when this occurs against a background of strong family history. And testing may help tailor the regimen and dose of anticoagulation. And then they say there's no evidence of clinical benefit of extended treatment if the patient is heterozygous for factor V Leiden or prothrombin gene mutation. The second scenario I wanted to, to talk about today is, again, young patient with unprovoked VTE, and the patient has first-degree female relatives, especially at, childbearing age. And in this setting, would you consider screening the patient for inherited thrombophilia with subsequent recommendation to screen their relatives if they're positive, or do you just recommend not screening the index patient, but maybe counseling their female relatives or their, family members for VTE in like high-risk situations? Looking, in general at family history and how that affects VTE risk. So this is a paper published in JTH in September of 2014, essentially a cross-sectional study looking at patients who were diagnosed with VTE between 2006 and 2012 that were presenting to 6 university hospitals, 5 in Canada and 1 in France. They looked at 138 cases with provoked VTE and 1,000 and their first-degree relatives, so 1,000 first-degree relatives, as well as 378 index cases with unprovoked VTE and 2,500 first-degree relatives. The limitations of the study is that they only tested for factor V Leiden and prothrombin gene mutation, and the follow-up of the first-degree relatives was retrospective. So that can introduce a lot of bias. And what the authors, note in terms of family history is that first-degree relatives of VTE patients have an elevated thrombosis risk, even without detectable thrombophilia. And both identified and unknown hereditary factors contribute to venous thromboembolism, especially in younger individuals and those with unprovoked events and a family history of thrombosis. And when they compared, family history of provoked versus unprovoked, they found that if you have a family member with unprovoked VTE, then your risk doubles your VTE risk doubles. And especially if your family member had thrombosis at a younger age, and they quote less than 45 versus over 72. But if you have essentially a family member who had an unprovoked event, especially before 45, then you're 3 times higher at getting a VTE. And the risk of these two is additive. And so this is sort of a graph showing, risk depending on the age in which the family member had the VTE, and you can see the highest risk is for patients who've had VTE before age 46. And then they also say, notice that the more family members that have VTE, the higher the risk. And it sort of doubles as you go. So if you have 2 family members, then your estimated risk is 2.47. If you have 3 family members, it goes to 3.54. 4 family members, it's 5.17. I'm trying to find my cursor, but I don't seem to be able to. Okay. Okay. So, and then the final notes, they say, if the index patient had factor V Leiden or prothrombin gene mutation, then the VTE risk in first-degree relatives really dependent on whether, you also had the same mutation. When we look at the guidelines and what they say in terms of, screening family members, so looking at the NICE guidelines, they say do not offer thrombophilia testing to first-degree relatives of people who've had history of DVT or PE and thrombophilia. The British Society of Hematology says we do not recommend offering routine thrombophilia testing to first-degree relatives, and they suggest selective screening of asymptomatic patients of probands with protein C, S, and antithrombin deficiency, where this may affect the management and life choices. And then ASH, again, for unprovoked VTE, they say do not test. Individuals with a family member of VTE and unknown thrombophilia status also do not test. But then they go on to say, if you have a family history and known thrombophilia status, they sort of separate patients with history of heterozygosity, factor V Leiden prothrombin gene mutation to say do not test. But then if you have the more thrombophilic mutations like protein C and S and antithrombin deficiency, they sort of discuss two strategies with either just testing for that specific mutation that runs in the family, or just completing a full sort of thrombophilia pattern, and using thromboprophylaxis in individuals with thrombophilia. And so, I think my takeaway from this is that patients with family history of VTE are at an elevated risk up to like 2 to 4 folds, even in the absence of a known inherited thrombophilia. And, I do wonder whether, I think first degree relatives, especially if we're seeing a patient with unprovoked VTE at a young age, if first degree relatives need to be informed of this risk and consider screening. Only if it would affect their management. And I think the challenge here is, thinking about all the young patients with unprovoked VTE that I've seen in the clinic, we don't typically ask about, how many family members do you have? And do you have any young, sisters at childbearing age, or how old are your daughters? And that's not something that I typically think about in clinic. And I think the last part I wanted to talk about, or third scenario I wanted to, discuss today was, asymptomatic female patient with family history of VTE and or thrombophilia that's referred to the thrombosis clinic before pregnancy planning, combined oral contraception, or hormone replacement therapy for postmenopausal symptoms. So first, looking at the risk of, VTE in pregnancy in the setting of inherited thrombophilia, we know that it's associated with an increased risk, especially for patients who are homozygous for factor V Leiden is sort of the highest risk. And similarly for the natural anticoagulant deficiencies up to 4. And that risk seems to be highest in the postpartum period. And so looking at the study that sort of nicely summarizes what the different sort of society guidelines have recommended, and this was published in 2022. So some of these guidelines, I guess, have been updated since, but we can see there's a lot of variability in what the different sort of societies recommend in terms of antepartum and postpartum screening. And looking at each mutation, it depends on whether they have a family history of VTE or not. And then depending on the mutation, they either recommend or don't recommend antepartum and postpartum anticoagulation. And so, just looking at this, whether or not a female patient has an inherited thrombophilia, does potentially affect how we manage her during pregnancy and whether or not she gets prescribed anticoagulation or thromboprophylaxis, especially in the higher risk mutations like antithrombin deficiency and protein C and S deficiency. When we look at the risk of VTE in terms of oral contraceptive use, there have been many studies looking at this. And this systematic review and meta-analysis published in JTH in 2016 looked at the risk of VTE during the use of combined oral contraceptive in patients who specifically had inherited thrombophilia. And they sort of separate, the risk for patients with a mild thrombophilia, so that's factor V Leiden and prothrombin gene mutation, to say that, the relative risk is, or the risk ratio is about 5.89. And, the studies, all of them have been fairly consistent in showing an increased risk with combined oral contraceptives. And then they talk about higher or more severe thrombophilia, so the antithrombin, protein C and S deficiencies, as well as the combined heterozygous patients. And they quote a risk of 7.15 for patients with inherited thrombophilia while on OCPs. To put that into sort of perspective for what that translates in terms of risk for these patients. Assuming that the baseline risk in the general population for these patients who are usually young is about 0.01% per year. If you do not have family history and you're sort of put on combined oral contraceptive pills, that increases your risk up to 4 times. The relative risk is 4, but that still translates to a very low risk of VTE. So that's about like 0.04% per year of use, per 100 years of use of combined, per 1 year of use of combined oral contraceptives. But if you have positive family history, we know that doubles the risk. So your risk goes up to 0.08, which again is still very low annual risk for VTE. But then in patients who have these deficiencies in the setting of family history of VTE, looking at the antithrombin protein CNS deficiency, that risk goes up to 4.6% per year in higher risk mutations. And then looking at HRT use in patients with inherited thrombophilia, again, typically these patients are older patients who use this for like perimenopausal, postmenopausal symptoms. So at baseline, they're at higher risk for VTE to start. And the studies have only like mostly been around factor V Leiden, and they're a bit of like older studies. But looking at the study published in JAMA in 2004, that is a double-blinded randomized controlled trial with a nested case control study that enrolled 16,000 postmenopausal patients between 50 and 79 between 1993 and 1998 with average 5.6-year follow-up. And they essentially, looked at baseline gene variants related to thrombosis in the first 147 women who were diagnosed with VTE and in 513 controls. And they found that if you were heterozygous for factor V Leiden and were on combined hormone replacement therapy, then your odds ratio for developing VTE was 6.69. And similarly, in this study published in Clinical and Applied Thrombosis and Hemostasis in 2010, again, they quote for patients with factor V Leiden, they quote an odds ratio of 17 for patients on combined estrogen progestin in the setting of inherited thrombophilia. So looking at the guidelines, again, what they say in the setting, so for ASH, they say, do not test women from the general population who want to start combined oral contraceptive or hormone replacement therapy. And you do not need to test if the patient has a family history without a specific known thrombophilia. But then again, they go on to say, if there's a specific known thrombophilia, you do not need to test if it's factor V Leiden or prothrombin gene mutation, but you do test in higher risk thrombophilia like protein CNS and antithrombin deficiencies. Which again, I think reasonable looking at the numbers of, risk for VTE in this setting. If we look at the British Society of Hematology, they say we suggest testing, again, asymptomatic relatives of probants with severe thrombophilias, where this may influence their management. So again, they don't recommend testing if it's just factor V Leiden or prothrombin gene mutation. And there's really no specific guidelines on this specific scenario in NICE or CHEST. This was published in NEJM about thrombophilia screening and in general in venous thrombosis in patients with inherited thrombophilia. And so they say, again, when to test. So if it's provoked by a strong risk factor, there is no role for testing. If it's weak trigger in a young patient with a family history and female members of childbearing age, then you sort of need to think about it. If it's going to change the management, maybe. So consider testing, they say, for factor V Leiden, prothrombin gene mutation, protein CNS and C, and also antiphospholipid antibody syndrome. So they don't really give a definitive recommendation. Then again, similarly for unprovoked VTE and VTE at unusual sites, they say determine the role of testing. Again, not very definitive language in terms of whether or not to test. And again, they go on to say, so identify goals of testing in order to aid decision-making for future VTE risk and guide testing of family members, depending on whether or not this would change management. And then looking, sorry, just give me a second here. Looking at this study that was published, it's sort of like a review article that focuses on factor V Leiden, published in JAMA just less than a month ago. And it specifically talks about when to screen or test for factor V Leiden. And so testing is indicated, they say, if pregnancy planning with a family history of VTE and potential homozygous factor V Leiden is suspected. And then they say testing may be indicated in pregnancy planning if there's a family history or multiple VTE risk factors, so like older age, obesity, and other medical conditions that increase risk. And then they say testing is not indicated if there's a history of unprovoked VTE, if it's provoked by major surgical procedure, if it's a healthy person who's considering combined OCPs or hormone therapy, unexplained pregnancy loss, and generally healthy people, then you do not need to test. And then I also came across this guideline that was published in April of 2025 in a journal called The Innovation. And the authors are sort of, the first author is from China, and then there's authors out of Europe and Canada as well. And I found this interesting, but they give this sort of summary of, when to test, what to look for, and then how to sort of treat each condition. But when we look at, when they think you should test is suspected hereditary thrombophilia. So they say VTE, VTE onset less than 50 years, neonatal fulminant purpura, recurrent VTE, multi-site VTE, poor response to standard therapies, warfarin-induced skin necrosis, which would make you think of protein C deficiency, VTE patients with a family history, and VTE at unusual sites. And then they don't really say, whether this is like a definitive, yes, you should test all of these patients or not. And then they sort of go into management of which anticoagulants, you can or should use in that specific setting. Notably in antithrombin deficiency, they say you can use DOACs or warfarin bridging without, and not use low molecular weight heparin specifically on its own. And then sort of to end, looking at this ASH article that was published after the guidelines came out in 2024, saying, does practice follow guidelines? And they looked at 100,000 VTE patients from the Right registry and assessed how inherited thrombophilia influenced anticoagulation use and outcomes. And they found that 20% of patients who were diagnosed with VTE were tested for thrombophilia. And they found that testing was more common in younger patients in VTE when it's related to estrogen, pregnancy, and postpartum. And in the setting of unprovoked and recurrent VTE, testing was more common. And then testing was less common in major transient risk factors like surgery, cancer, and immobilization. So again, thinking about limitations and adverse effects of testing, we have to think again on an individualized basis how this will affect each patient. Does it limit their ability to maybe obtain health or life insurance if they were otherwise healthy? Does it cause undue psychological stress if they know that they have an inherited mutation? And considering it probably doesn't really affect, their VTE risk in the future. And would it provide false reassurance if you have a negative test and you think this patient needs to remain on anticoagulation long term? So I think my takeaway from this is I think testing in the end should be personalized and purpose driven. So only testing if I think that it would change the management of the patient in front of me or how I counsel them. And I think in the end, the clinical context of how the VTE happened is more informative than, having the mutation itself. I think anticoagulation decisions in the end, from what I've seen in clinical practice, rarely depend on whether or not a patient has an inherited thrombophilia. Where I think mostly, makes a difference is in the setting of family planning and reproductive risk. So testing asymptomatic individuals if I have a high suspicion that they have an inherited thrombophilia, and I think it would change, whether my recommendation for combined OCPs or pregnancy management. And I think in the end, it should be sort of a shared decision before going ahead with testing. And just looking at the guidelines, I found that they either provide very vague language for the recommendations, are usually conditional recommendations, not strong ones, and they're sort of inconsistent across societies. With some sort of recommending not testing, for example, on patients with unprovoked VTE, and others suggesting yes, you do need to test. And then I think uptake into clinical practice seems inconsistent when we look at sort of real life who gets tested, which highlights the importance of expert judgment and I think individualized care. And then I'll open, I guess, the floor for questions and any thoughts.